to high anion gap metabolic acidosis. So my outline of the talk will be based on definitions, basic analysis of an acid-base disorder, discussion on cases representative of high anion gap metabolic acidosis. So as George has said, it is interesting to know a bit of history about the legends of acid-base physiology. And this is a first man who pioneered us into the area of acid-base physiology. This is Lawrence Joseph Henderson. He is an American physiologist, and he was a multi-talented guy. And apart from physiology, he had interest in uh, sociology. And he, in fact, was very much interested in the urbanization of the society, and he has published a lot of papers in sociology. So, multi-talented guy. He first gave the equation of the Henderson's equation, which linked the carbon dioxide and PCO2. So, this is a basic equation by which we check the internal validity of an ABG report. This is a Hasselbeck, this is a Danish physiologist, and he is the one who linked the pK of the solution, that is the dissociability coefficient of a buffer system, with the Henderson's equation. And so we get the famous Henderson-Hasselbeck equation. And this is Peter Stewart, another legend in the field of acid-base physiology. And it is amazing to know that he had a very different perspective of acid-base physiology. It requires a brilliant mind to analyze things in a different perspective. So these are actually the legends of acid-base physiology. Now, coming to the arterial blood gas analysis. So these are the complex modern blood gas analyzer. This is capable of reporting pH, PCO2, PO2, saturation of oxygen, sodium, potassium chloride, calcium, hemoglobin contents, methemoglobin, oxyhemoglobin, carboxyhemoglobin, lot of things, reduced hemoglobin, everything. And this is a measurement chamber of a modern blood gas analyzer showing the measurement electrodes. And we have handheld devices as well. Now, when you get an arterial blood gas report, you should know what the the normal arterial blood gas values are. So these are the normal arterial blood gas values, and everyone is familiar with these normal values. Now we'll come to certain definitions. I'm just going through it because to lay a foundation for the cases that we are going to discuss. So metabolic acidosis and acidemia is a state where there is a decrease in the blood pH, where there is an increase in the blood hydrogen ion concentration. Alkalemia is a state where there is a decrease in the blood hydrogen ion concentration, and the pH is the inverse relation of hydrogen ion concentration. So when the hydrogen ion concentration increases, the pH decreases, and you have to see which is the primary change. If the primary change is in the bicarbonate, you call it as a metabolic problem, and if the primary change is in the carbon dioxide, you call it as a respiratory problem. So metabolic acidosis, the pH will be less than 7.4. The primary change will be the drop in the bicarbonate, and the compensatory change will be a decrease in the PCO2. This happens because of the Henderson-Hasselbeck equation, which tries to maintain the pH at normal. And the metabolic alkalosis is where the pH is more than 7.4 and the bicarbonate is more than, where there is an increase in the bicarbonate, and as a compensatory response, there will be increase in the PCO2. The reverse hold for respiratory acidosis, where the pH is less than 7.4. The primary problem is an increase in the PCO2, and the compensatory response is an increase in the bicarbonate. And in respiratory alkalosis, the pH will be more than 7.4. The primary problem is a decrease in the PCO2, and as a compensatory mechanism, there is a decrease in the bicarbonate. So these are the acid-base terminologies that we commonly use. And the primary change is an abnormality. Primary change is an abnormality in either the serum bicarbonate or the arterial PCO2, resulting from a primary change in the body function. And the secondary change is a compensatory mechanism. And a simple acid-base disorder is there is only one primary disorder with an appropriate secondary response. And a mixed acid-base disorder is a simultaneous occurrence of two or more primary disorders. So how do you evaluate an acid-base disorders? Basically, there are three methods which are available. One is a physiological method, which is based on Bronsted-Lowry's definition of acids and bases, and is based on the bicarbonate carbon dioxide buffer system. The second one is a base access method, which is by Sigurd and Anderson. And the last one is a physicochemical method, which is proposed by Peter Stewart. All these techniques have their own merits as well as demerits. And for the lack of time constraint, we are sticking only to the physiological method. And this is a method that is commonly followed in our hospitals, and it is a classical teaching method. And the physiological method, the advantage is it can be easily applied on the bedside. And you can actually interpret complex acid-base physiology is based on anion gap. The anion gap will tell you about what the cause of metabolic acidosis is. Then the other advantage is that this is simple, and the mixed acid-base disorders can also be worked out from the physiological method. However, there are certain drawbacks, like it is based only on one buffer system. It does not take into account the whole of cations and anions, and the relationship between pH and hydrogen ion concentration is not linear. So we are not going into the merits and demerits into all the systems, but we will be confining ourselves to the physiological method. So the physiological method, one of the basic concepts that we need to know is what is known as an anion gap. So in anion gap, to maintain electron neutrality, the total anions should balance the total cations. That is a basic assumption. So the anions include chloride, bicarbonate, and unmeasured anions, which should be unequal to sodium along with unmeasured cations. So anion gap is a measure of unmeasured anions, or it is the difference between unmeasured anions and unmeasured cations, which is equal to, if you rearrange the equation, you will see that it is something like sodium minus chloride plus bicarbonate. So this is the anion gap, and the normal anion gap is roughly taken as 12 plus or minus 4, and often a mean value of 10 is taken. But with the advantage of newer ion-specific electrodes, the value has even come down. So in some centers it is taken as somewhere between 3 to 9. But you should have a working idea of what the anion gap is there in your lab, and you should follow your lab's criteria. So we'll see what the unmeasured cations are. The unmeasured cations are namely potassium 4.5, calcium it is 5, magnesium is 1.5. When you add up, it is total is around 11. The unmeasured anions with albumin it is around 12. Other proteins are around 3, phosphates around 2, sulfates around 1, organic acids around 1. So this comes to around 23. So unmeasured anions minus cations, it is approximately somewhere between 12 plus or minus 4. So based on the anion gap, you can classify an acidosis into high anion gap acidosis or HAGMA. Then you can have a normal anion gap acidosis or NAGMA, and you will have a normal low anion gap acidosis. So our topic of discussion today will be sticking only to high anion gap metabolic acidosis. So high anion gap metabolic acidosis, there are a lot of mnemonics available for this. One of the commonly used mnemonics are gold mark. Gold mark refers to glycols, oxoproline, L-lactate, D-lactate, methanol, aspirin, renal failure, and ketoacidosis. And certain additions like you need updated mnemonics when new causes are being discovered. So you can have rhabdomyolysis, toluene intoxication, then type B lactic acidosis. These things are recently come into notice, and these are picked up quite often nowadays, especially in the critical care medicine department. You can have malignancy, liver failure, thiamine deficiency, drugs like metformin, nucleoside reverse transcriptase inhibitors, linezolid, toxins like carbon monoxide and cyanide. So all these are additional costs. So in general, it is related to intoxicants. If you want a broad classification, you have to think about intoxicants as well as other metabolic conditions causing high anion gap metabolic acidosis. So our topic will be confined only to this group of causes which lead to high anion gap metabolic acidosis. Now there are certain conditions which can lead to normal anion gap metabolic acidosis. Normal anion gap metabolic acidosis is characterized by conditions which are characterized by the loss of bicarbonate either in the stool or in the urine, so that there will be a hyperchloremia as a mechanism, and so that the anion gap is not disturbed. So the common conditions include diarrhea, urethral diversion surgeries, then renal tubular acidosis. We won't be going into these things, into these causes, because it will need a separate discussion by itself. And the other causes are low anion gap metabolic acidosis. Sometimes once in a while you come across low anion gap metabolic acidosis, especially in conditions like myeloma. In myeloma, the IgG, if there is an IgG myeloma, the IgG levels will be high, and these IgG levels can cause a low anion gap metabolic acidosis because of the positive charge of this myeloma proteins. Then you can have hypoalbuminemia as a cause, hypercalcemia and hypermagnesemia. Lithium toxicity is one cause. All these things can sometimes lead to a low anion gap metabolic acidosis. In general, metabolic acidosis is due to three causes. One is loss of bicarbonate either from the gastrointestinal tract or the kidney, which will lead to a normal anion gap metabolic acidosis. Retention of hydrogen ion due to impaired renal function. Classical example is chronic kidney disease. Then there is addition of exogenous or endogenous strong acid. Now, how do you evaluate an acid-base disorder, especially metabolic acidosis? So there are at least 9 or 10 steps involved in the analysis of an acid-base disorder. So you have to measure the electrolytes and arterial blood gas simultaneously or within a few minutes apart. because there are the conditions can vary rapidly. So you need an almost simultaneous or within a short interval simultaneous measurements. And you have to check the validity of the blood pH using the Henderson's equation. Then you have to identify the primary disorder. You have to calculate the anion gap, and the anion gap has to be corrected for low albumin. If the albumin is low, you have to identify the causes of the primary disorder. You have to calculate the expected compensation or the secondary response. In the clinical scenario, it is called compensation, but in physiology, it is called a secondary response. And you have to identify the mixed acid-base disorder, if any. And in high anion gap metabolic acidosis, always you have to use a delta ratio. We'll come to it later. And in appropriate scenarios, you have to use urine anion gap, urine pH, plasma osmolar gap, urine osmolar gap. All these things should be discussed, should be taken into context based on the clinical scenario. So, for example, we'll deal with one case. So, there is a 30-year-old man with a long history of intravenous drug abuse. He is admitted for weakness and abdominal pain. His respiratory rate is 24. This is the blood gas values. Sodium is 136, potassium is 5.1, chloride 100, bicarbonate 14. Blood urea nitrogen is 120, creatinine is 10, glucose is 90. And you will always see a discrepancy between bicarbonate when it is measured by in the blood, in the venous blood, with the bicarbonate which is measured by the arterial blood gas. And always serum electrolyte, the serum bicarbonate will be more than the APG bicarbonate because it measures the total bicarbonate. And there will be the pH of this patient is 7.28, PCO2 is 30, PO2 is 100. So the electrolytes and the blood gases were done simultaneously in this patient. Now you have to use a Henderson's equation. Henderson's equation will give you the hydrogen ion concentration, which is equal to 24 into PCO2 divided by the bicarbonate. Here the PCO2 is 30, the bicarbonate is 40. So the hydrogen ion concentration is around 51.4. So if you have this table which tells you what is the pH with regards to the hydrogen ion concentration. So if you see 51 is a hydrogen ion concentration corresponds to somewhere here, that is pH of 7.3. So the internal validity of the equation, the blood gas is corrected. So this is a correct blood gas report. You have to identify the primary disorder. So the primary disorder being the pH is low, the bicarbonate is low, so it is a metabolic acidosis. Then you have to calculate the anion gap. So the anion gap is calculated by sodium minus chloride plus bicarbonate. And if there is an correction for albumin, you have to do that correction for albumin as well. So the correction for albumin is 12 or 10 minus 2.5 into this is equation. So for every 1 gram drop in serum albumin, the anion gap goes up by 2.5. So you have to look the albumin value and you have to correct albumin value accordingly. So that is then you have to identify the cause of the primary disorder. So the cause of the primary disorder in this condition would be the creatinine is 10. So it is quite obvious this patient is having a kidney failure and he is retaining hydrogen ion. And you have to calculate the expected compensation. So expected compensation is calculated by a formula known as a Winter's formula, which tells you that the PCO2 is equal to bicarbonate into 1.5, the whole thing plus 8 plus or minus 2. So here when you calculate it will be something like 14 into 1.5 plus 8, approximately it comes to around 29. So the PCO2 in this patient is 30. So the Winter formula will give you the compensation. So it is adequately compensated. So there is no added element of a respiratory problem here. So if you have got a respiratory acidosis, carbon dioxide will be high. And if the respiratory alkalosis, it will be less than 29. Then you have to identify the mixed base disorder if there is any, and use delta ratio appropriately. And since it's a primary disorder, often you won't require a blood delta ratio if there is adequately compensated. But it is worthwhile if it is a metabolic acidosis to look for delta ratios. So, and in general, the treatment of metabolic acidosis when the pH goes down to less than 7.2 is sodium bicarbonate. And if it is less than 7.1, it severely impairs with the cardiac contractility. Then often you require dialysis or some sort of a supportive treatment. And the treatment, the last step, which would be included is a treatment. So you have to identify the cause and treat. So the treatment is the cause. What is the reason for this acid-base disorder? You have to treat that acid-base disorder. And you are not supposed to correct the electrolytes blindly. The cause always has to be addressed. Because unless and until you address the cause of this acid-base disorder, you are never going to correct the acid-base disorder. Then there is another thing which is known as a delta. Delta is anion gap minus a normal anion gap divided by the bicarbonate minus the actual bicarbonate that you got. And the delta will give you, the delta ratio will give you if there is any additional things which are hidden in this problem. So if the delta ratio is less than 0.4, you are dealing with a hyperchloremic normal anion gap acidosis. If it is somewhere between, in a pure anion metabolic acidosis, high anion gap metabolic acidosis, the ratio will be 1. Because for every 1 milliequivalent per liter fall in the anion, increase in the anion gap, there will be a decrease in 1 milliequivalent of bicarbonate. So the ratio will be 1. And in lactic acidosis, the standard value is around 1.6 because apart from bicarbonate, it is buffered by other bone buffers as well as blood protein buffers. Then if the ratio is more than 2, you have to think about a coexisting metabolic alkalosis. Now, another thing that you normally do is when you are dealing with a metabolic acidosis, what is known as a serum osmolar gap. Serum osmolar gap is a difference between the measured serum osmolality minus the calculated serum osmolality. So the normal serum osmolar gap should fall in the range of -10 to +10. And if it is more than 10, then you have to consider it is a positive serum osmolar gap. And more than 15 is considered as a critical value. So how do you calculate the osmolar gap? We'll come to it once the problems are discussed. Now, these are the conditions which are associated with an elevated serum osmolar gap, along with this elevated serum anion gap. So elevated serum osmolar gap with the increased serum anion gap, you have to think about organic alcohol ingestions like methanol, ethylene glycol, diethylene glycol, and propylene glycol. Then diabetic ketoacidosis, salicylate toxicity. And without an elevated anion gap, you have to think about one alcohol which falls it with a without an elevated serum anion gap is isopropyl alcohol because it produces acetone. So, and no anion gap is seen. Then hypertriglyceridemia, hyperproteinemia, hyperosmolar therapy, and other organic solvent ingestions. Now we'll come to a few cases. So a 60-year-old man is admitted for a 2 week history of cyclic fever, weight loss of around 10 pounds, nausea, vomiting, and night sweats. So this is a history. He's not on any medications and has not seen a physician in years. Physical examination is normal except for a blood pressure of 100 over 40. Heart rate is around 102 beats per minute. There is no lymphadenopathy. His current weight is 74, but it is to be noted that he has lost around 10 pounds. So these are the values which have come. So the sodium is 142, potassium is 4.2, chloride is 104, bicarbonate is 8. So he's running a metabolic acidosis. The pH is 7.2 with the bicarbonate of 8 and the creatinine is 1.8, the glucose is 64, uric acid 9.4, measured osmolality is 312, and you are also given a lactate dehydrogenase value which is around 690. The total cell count is 8.2. So the primary acid-base disorder is a high anion gap metabolic acidosis. The anion gap, when you calculate the anion gap will be high. So the sodium 142 minus chloride, this comes to around approximately 38. 38 minus 8 is around 30. So this anion gap is around 30. Then the osmolar gap is 14. So you have to here the how do you calculate the calculated osmolality is based on equations which you all know. You have to take into account the osmolality is based on sodium, the glucose, as well as the blood urea nitrogen. And if he has consumed any alcohol, you have to correct for ethanol also. Ethanol, the correction value, the denominator is 3.7. So the osmolar cap is 14. So the question is, do you suspect any alcohol intoxication? So there is no history which suggests an alcohol ingestion, but the osmolar cap of 14 should be attributed to other causes other than alcohol. So the anion cap is 30. Anion gap is 20. So the observed anion gap minus the normal anion gap, that is 30 minus 10 is 20. So the delta anion gap is 20. And there will be, so the delta anion gap is 20. So this means that there are 20 excess anions in this patient. And of these 20 excess anions, mostly the lactate would account for 14 and the remaining anions are possibly from keto acids. So if you measure the lactate level and you have to, in every high anion gap metabolic acidosis, it is worthwhile. You have to measure a lactic acid level, you have to measure a keto acid level. And if you are suspecting toxins, you have to have a toxin assay also. So this condition is, based on this clinical presentation and a high lactate level, the consultation that is required is a hematology oncology review. So this problem is known as a Warburg effect. So Warburg is first scientist who delineated this problem, and it is often found that in patients with malignancy, the malignant cells will increase the glycolytic pathway. So the glycolytic pathway is a defense mechanism of the cells, and they convert the pyruvate into lactate, and the lactic acid level builds up in the cells, and the lactic acid diffuses outside the cells and makes the external environment acidic. And an acidic environment is very favorable for the malignant cell growth and metastasis. So this effect is known as Warburg effect. And this is the mechanism. The glucose is converted to pyruvate. Pyruvate is converted by lactate dehydrogenase into lactate. And this pathway is stimulated by this malignant cells because of the overexpression of lactate dehydrogenase. And pyruvate, if it is, it undergoes oxidative phosphorylation and enters a Krebs citric acid cycle to be further broken down into ATP molecules. So we are dealing with a type A lactic acidosis. The lactic acidosis can be classified into type A, type B. And type A, the causes include shock. The most important causes include shock. In almost all the causes of shock, there will be a decreased oxygen delivery, increased glycolysis, decreased ATP, and increased pyruvate production. Then other causes include anemia, asthma, and carbon monoxide poisoning. Then systemic diseases include liver disease, diabetes mellitus, kidney replacement therapy, ATP depletion as an anaerobic glycolysis. Seizures is one condition which we commonly see, and liver disease is one of the most common scenarios which we encounter. And lactic acidosis type B can also be subclassified into type B2, which include metformin, ethanol, methanol, ethylene glycol, propylene glycol, salicylates, cyanide poisoning. Then these classes of drugs are important. Antiretroviral drugs. Linezolid is one drug which can is directly toxic to the mitochondria. Propofol, if you are on propofol for more than 48 hours, it can cause what is known as a propofol infusion syndrome, characterized by lactic acidosis and rhabdomyolysis. Sodium thiosulfate, which we use in the treatment of calciphylaxis, can also cause. Because of the paucity of time, I am not going into the intricacies of each of these mechanisms. Then you have to remember there is one condition which is known as D-lactic acidosis. Normally, the carbohydrates that we ingest are metabolized in the small intestine. And in the small intestine, they are completely metabolized and digested, so that none of them enters, very little enters the colon. And if you have a short bowel syndrome, like if the length of the bowel is less than 150 centimeters, what will happen is that the carbohydrates that we ingest, that we consume, are not completely broken down. They enter the colon, they are fermented to organic acid. And these organic acids will decrease the production of bacteria which are mainly producing L-lactic acid, and there will be an increased proportion of bacteria which will produce D-lactic acid, and the humans don't have the capability of metabolizing D-lactic acid. So what will happen is that the D-lactic acid level builds up in the body, and it is D-lactic acid is a stereoisomer of L-lactic acid. The D-lactic acid level builds up in the body, and the patient will go into lactic acidosis. And the importance of this condition is that you will have a high anion gap metabolic acidosis, but at the same time lactic acid levels will be normal, because biochemical instruments will only pick up L-lactic acidosis. So you have to think about this condition whenever there is a high amount of lactic acid in the blood, whenever there is a high anion gap metabolic acidosis and lactic acid is normal, and if there is risk factors like short bowel syndrome, intestinal bypass surgery, prolonged antibiotic use, which will destroy all the normal colonic bacteria. And the main manifestations are neurological, like altered mental status, ataxia, abnormal gait, disorientation, nystagmus, hallucinations, etc. So these conditions have to be kept in mind. And how do you make a diagnosis? You have to actually, if you want to measure D-lactic acid, you should have a lab which will actually do a D-lactic acid level. And in the scenario of this high risk situations, you have to think about D-lactic acidosis, and dialysis will correct the cause, and you have to address the primary cause itself. So this is a pathogenesis and pathophysiology of diabetic ketoacidosis. So another cause of a high anion gap metabolic acidosis is diabetic ketoacidosis, where there is a relative or absolute insulin deficiency along with an increased counter-regulatory hormones. Here there will be a decreased utilization of glucose, increased lipolysis, increased proteolysis, and increased glycogenolysis. All these ultimately lead to hyperglycemia. And as hyperglycemia will lead to a shift hyponatremia. It will lead to glycosuria, dehydration, and hypolemia. And because of this increased lipolysis, free fatty acids are delivered to the liver. It increases the ketone body production, and there will be ketosis, and there will be ketosis, and there will be high anion gap metabolic acidosis. And in addition, there can be a degree of lactic acidosis as well. Then another cause of a alcohol ketoacidosis is an alcohol ketoacidosis. If you have increased ethanol intake, you will have increased production of acetate. Acetate is converted into all the ketone bodies, which will lead to some degree of high anion gap acidosis here is due to the ketone bodies produced as a direct metabolism of alcohol. The other cause is whenever you convert ethanol to acetate, there will be a alteration in the NADH-NAD ratio. So the NADH level will go up. Whenever there is an increase in the NADH, it will increase the glycolytic pathway, and the glycolytic pathway gets stimulated. Then there will be glycogen deposition, depletion, and there will be an increased ketogenesis. Ultimately, it leads to alcoholic ketoacidosis. So we'll find up with this final case. This is a 54-year-old woman who is admitted through the emergency department with the shortness of breath. The blood pressure was 111 over 51. Pulse rate is 69. She's febrile. There is cervical and lumbar disc disease, hypertension, depression, anxiety, ataxia, chronic pulmonary obstructive disease. She had cholecystectomy and hysterectomy in the past. Medications include metered dose inhalers, metoprolol, clonazepam, and Vicodin. And the patient was previously admitted with similar complaints and was found to have a high anion gap metabolic acidosis and acute kidney injury, requiring a short-term dialysis. And the lab studies are like this. Hemoglobin is 13.4. The glucose was 80. Blood gas shows a pH of 7.2. PCO2 is 15. PO2 is 91. And the calculated bicarbonate is 6. The anion gap was 16, and the urine osmolality was serum osmolality was 293, and the serum ketones and the lactate were negative, and the urinalysis was normal. So this is a acid base. You have to. I'm not reading it aloud. So you have to know that the pH is 7.2. The bicarbonate is 8, and the anion gap is found to be 16. So this is a high anion gap metabolic acidosis. The creatinine initially is 0.8. Now, the acid-base disorder is a high anion gap metabolic acidosis. And if you work out the Winter formula, you'll find out the patient is also having a respiratory alkalosis. So the osmolar gap in this patient is around 6. So since the osmolar gap is less than 10, it is not significant. Now, is aspirin overdose a possibility in this patient? Aspirin overdose can cause, initially it causes only respiratory alkalosis, which is followed by a high anion gap metabolic acidosis. So of course, you have to think about aspirin toxicity, and a serum salicylate level should be done. Now, toluene inhalation. Toluene inhalation is recently one of the causes of high anion gap metabolic acidosis and a hyperchloremic metabolic acidosis. Then you have to exclude a toluene toxicity. We are not going into the details now. Now, she's not the most important thing in this patient is she's a high dose of acetaminophen, 750 milligram 8th hourly. So you had to order a urinary pyroglutamic acid level, and it was found that the urinary pyroglutamic acid level was very high, and this is a classical presentation of a pyroglutamic acid toxicity. So this is a metabolic pathway of glutamate. Glutamate is converted into gamma glutamyl cysteine, then it is converted into glutathione. Glutathione is converted into this pyroglutamic acid. This is a degradation pathway. Now, when you are using a lot of paracetamol, the paracetamol will deplete the glutathione. And glutathione causes a negative feedback on this enzyme. This is a gamma glutamyl cysteine synthetase. So when the glutathione levels goes down, this inhibitory effect is broken down, is taken off. So more glutamate will be converted into gamma glutamyl cysteine, and the gamma glutamyl cysteine will be converted into pyroglutamic acid by this particular enzyme. So the pyroglutamic acid level builds up in these patients, and this causes a high anion gap metabolic acidosis. So coming to the toxins which causes a high anion gap metabolic acidosis, I'm just going through the list. Methanol, ethylene glycol, diethylene glycol, propylene glycol, isopropyl alcohol. Remember that it produces a almost normal serum anion gap. Salicylate, 5-oxoproline, acetaminophen, toluene, and paraldehyde. Then these are the toxic metabolites with regards to all these substances. Methanol, the toxic metabolite is formic acid. Ethylene glycol, it is glycolic acid. Then propylene glycol, it is lactic acid. Isopropyl alcohol, it is acetone. Acetyl salicylic acid is salicylate. Then the antidotes which are available are fomepizole, ethanol. Then of course you have to do dialysis. Then hemodialysis is what are the indications of doing hemodialysis in a patient with methanol toxicity? The indications are in general, with the advent of fomepizole, the routine use of hemodialysis is diminished, but it is still used in situations where if you are treating with ethanol and if the methanol level is more than 50, you have to consider hemodialysis, kidney dysfunction, visual impairment, or severe acidemia. I am rushing through because of the paucity of time, and this is a really exhaustive topic. Now, in the future, it is one thing which we can definitely anticipate is the use of artificial intelligence in interpreting ABG reports. So this is a paper which has been published recently, which assesses the accuracy of ChatGPT in interpreting blood gas analysis. And if you are using this Google Gemini, I've tried it. You just read the values to Gemini, it will give you an interpretation. So soon will be augmented physicians and will be more relying on AI. So ChatGPT is going, or some other artificial intelligence platform is soon going to aid us in interpreting this blood gas reports. Thank you.